So now let's talk about some breathing patterns and some terminology, things that you need to know and understand. You need to know what these are and be able to classify them. Um, they're listed, spelled out more specifically on page 946 out of your text, volume 1. Eupnipnea or eupnea is normal respiratory rate, 10 to 20. Now you got to keep in mind to put this in context. Someone who is an athlete, when they are at rest, their respiratory rate is lower than the norm. Also, someone who is obese, their respiratory rate might be higher. If because of their metabolic rate and so forth and so on. So all this has to be placed into context. Tachypnea is the rapid shallow respiratory rate of 24 or more. Bradyapnea or bradyapnea, slow rate less than 10. Kussmaul's respiration, this is, you'll see with hyperventilation and fear and anxiety. It's a regular respiratory rate, but they're increased. So they're a nice even pattern. They're just fast, okay? Biots or biots, depending on where you're from, it's irregular in depth, but usually shallow, alternating with periods of apnea. You'll see this in patients who have brain injuries with increased intracranial pressure. The worse this is, the higher the intracranial pressure traditionally. You also have what we call Cheyne-Stokes respirations. You'll see that some of your older nurses say they got the death breathing going on. This is usually associated with someone who is actively dying. It's a gradual increase in the depth of respiration followed by a gradual decrease. So they'll breathe really deeply 5, 6, 10, 12 times, and then they'll do the same thing very shallowly for a few times, and then they'll have some apnea. Usually some intracranial pressure is increased, but you also see this as people are actively dying. Apneic periods, it's a temporary cessation of breathing, could result from a reduction of stimulus to the respiratory center, when your CO2 is reduced, when we hold our breath for whatever reason. You'll also see it in Cheyne-Stokes. You'll see it in sleep apnea, so forth and so on. And pure apnea is the absence of breathing or respiratory arrest in which we are required to do, well, not always, but we need to manually ventilate or provide respirations for this individual. So in your stagnant slides, if you hit the video link up top, this man will actually breathe and whatnot for you. You'll see a video of him, but I'm not going to do that for purposes of here because of the storage data and so forth. But when you see him do this, you'll see his nares, or he's got some nasal flaring. As he breathes in, his nose will open up to help bring in more air. He's got some circumoral cyanosis going on around his lips and in his mucous membranes and his sclera. He will be using some accessory muscles. That's those muscles. If you can see my cursor right through here. And men are belly breathers, so not so much down there, but he may have some numbness and tingling in his hands and feet. He's going to purse lip breathe, kind of like you're blowing up a balloon. That may have some coughing with some high-pitched barking sounds. Or wheezes, a rattle or a crackle. You've heard those in health assessment, or you will soon. He may also have an altered level of consciousness or impaired mentation. He could be completely unconscious, might be dizzy because of the CO2. He could be restless, anxious, confused, might be combative, or might just be irritated. Either way, those are signs, some early signs, or some signs of hypoxia. So when our respiratory effort is increased, we have distress or respiratory distress. Dyspnea is the term we use, shortness of breath. Old nurses like me will just say got some shortness of breath, and we used to write that as SOB. We don't do that anymore. We use the term dyspnea, so same thing, but you'll hear some older people say shortness of breath. He's got shortness of breath. Orthopnea occurs when you're lying flat. It causes the person to want to sit upright or sleep up in a chair or on multiple pillows. The person does not have to be asleep to experience orthopnea. It's when you have to lie them down flat that they can't breathe. Paroxysmal nocturnal dyspnea. It's attacks of dyspnea and coughing that generally occur at night. It usually awakens the person from sleep and may be rather frightening because they just sort of wake up because they can't breathe. So it's sort of misleading because it says nocturnal, meaning at night, but it's really during the sleep pattern. So if someone works night shift, third shift, and they sleep during the day, they still have paroxysmal nocturnal dyspnea because it's happening when they are sleeping. It really is deceiving because it says at night. It's usually when they're sleeping. Conversational dyspnea, clients become breathy or they can't breathe as they speak. You will see this a lot in your older COPD patients, your chronic obstructive pulmonary disease patients. They talk like this. They can only say a few words, and then they have to stop because they can't breathe. Okay, stridor, very high pitched, sounds like a goose kind of sound. Wheezes, very high pitched whistly sound. Your Jarvis textbook for health assessment has tons of videos, etc., for you to listen to, or it should, for breath sounds. But you can also go to this YouTube video if you choose to listen to some of those breath sounds. But that's really more covered in health assessment than we're. So part of our assessment for oxygenation and perfusion also includes measuring our pulse oximetry. That's measuring looks at the hemoglobin and how much oxygen is sitting on the hemoglobin molecule. For a normal healthy individual, even if you've got the flu, it should be in the 95 to 100% range. Okay. Um, it's used in newborns to screen out congenital heart defects, but that's a long, convoluted process. But anyway, COPD patients have a normal range of 88 to 92. Now, that's important because of the way a pulse oximeter works. The pulse oximeter is looking for an NO2 molecule. Okay, so it's measuring not only the oxygen molecule, the O2 molecule, it's also measuring and sees the CO2 molecule. It sees the O2 portion of the CO2 molecule. So that's really important to understand because if you have a COPD patient who their highest, if they're bad enough, should be a 92, and you plop that pulse oximeter on them and it reads 99, like in this little picture, something's not right. Okay, it actually is right. It doesn't make sense. What's happening is that pulse oximeter is reading the CO2 molecule and not the oxygen molecule. So you're getting a false high. So if you slap that pulse oximeter on somebody who's in severe respiratory distress and it says 98, 99%, you need to do some further investigation because it has room, it has extreme room for error here. Okay, goes back to the adage: treat your patient, not your monitor. Okay. So let's talk about a cough. Everybody does it one way or the other because we're exposed to irritants, whether consistently or periodically. Irritants like dust, cigarette smoke, fumes, pollen, cat hair, dog hair, whatever. Okay, so it's our body's way to try to get this irritant out. We have a couple of types of cough. We have a dry cough, we have a productive cough, and we have a hacking cough. A dry cough is exactly what you think it is. It's someone or a cough where there's not any mucus being brought up. Okay, it's just a dry cough. A productive cough, on the other hand, is when someone coughs and they bring up mucus. A little bit of it, a lot of it. Okay, doesn't matter. It's productive. A hacking cough can either be dry or productive. Okay, so a hacking cough is just a little cough that is irritating and it won't go away. But then it'll go away for a while and then it'll come back, or it's been there for a while. Okay. So what's important when we have a person who's coughing is ask them some typical questions. How long have you had the cough? What makes it worse? Uh, what have you used to treat it? Has it been effective? What other symptoms do you have? You got a runny nose, sneezing, watering eyes, you got a temperature. Are you congested? What do your lungs sound like? When you bring up the sputum, what does it look like? And we'll talk more about that in a minute. Um, and any chest tightness, wheezing, anything like that. So it's important to delve into a cough and see what's behind the cough. Which then leads us to sputum or spit or phlegm or whatever you want to call it. It's the thick stuff that we cough up out of our lungs and from our upper airway. Traditionally speaking, if it's white or clear, it could be viral or a cold or normal, okay, as a result of an allergy. Uh, Historically, green or yellow could be infection, but now we're seeing that not so much. It could also be clear and infection. Okay, black sputum is the result of an inhalation of smoke or soot, as you know, like a fire or being around a fire pit for too long. Rusty colored, pneumonia, tuberculosis, possible presence of blood if it's rusty. Hemoptysis, that's when it's very red, like the middle, I think the middle top picture and bottom picture, I would call that hemoptysis. There's blood in that. Okay. Pink and frothy, there's not an example of that in the picture below. It's pink because it's got blood tinge. It's blood tinge. It's frothy. It looks like if you shake up a soda, how the carbon dioxide rises to the top. It's frothy like that. That's indicative of pulmonary edema. Person's in deep trouble when they're there. Foul smelling. You know, don't go sticking your nose in it. If it stinks, you're going to be able to smell it. Okay. That being said, Chapter 36 of Volume 2, Procedure 36-1 has pictures of sputum and various colors and appearances and what they mean. Okay.